Hello, my name is Christopher Andrews. I'm a gastroenterologist at the University of Calgary in Alberta, Canada. And today I'm going to speak about our recently published article in Gastrointestinal Endoscopy entitled Percutaneous, Endoscopically Assisted, Transenteric Full-Thickness Gastric Biopsy, our initial results in humans. Now, the reason and the motivation for us doing this study is that there's very many people with severe organic motility disorders, things like gastroparesis or intestinal pseudoobstruction, for example. And these patients suffer quite a lot, but we do not have very good tests to very comprehensively make the diagnosis. Recently, a number of studies have come out that have suggested that looking at full-thickness gut wall biopsies may help diagnose these disorders. And in fact, there's a new classification based on histology called the London classification, published in 2010 in Gut. With taking full-thickness biopsies is a novel way of diagnosing these disorders, because in the past we typically would just make the diagnosis based on functional testing like gastric emptying studies or other types of imaging, or really just based on symptoms. And that made it very difficult for us to understand the pathophysiological process that's ongoing inside the gut wall. Now, the reason that you need to do a full-thickness biopsy is because mucosal biopsies do not actually show the enteric nervous system, the myenteric plexus, the network of nerves and interstitial cells of Gall that run the functions of the gut. And so typically a laparoscopy was used to take a full-thickness biopsy, but that entails doing a general anesthetic and a surgery, and typically an overnight stay. The drive of our study was to find an easier way to do it as an outpatient procedure, and that's what we've developed with this percutaneous method, which in short form is PEAT, P-E-A-T-E, full-thickness gastric biopsy. I'm going to demonstrate this biopsy, and then I'm going to show a brief video clip of the procedure done in an actual human. I'll now demonstrate the actual needle procedure. The needle we used is a standard available Cook Quick Core 14 gauge needle. It's a spring-loaded biopsy gun that is typically used for things like liver biopsies and prostate biopsies. There's a handle and a 20 centimeter long needle. At the end, the needle is sharp, and this is the way that it is inserted into the wall of the stomach. This is a close-up of the needle tip. This is the closed configuration, which is the way that the needle is inserted through the skin and into the gastric lumen. Once inside the lumen, the needle notch is exposed. As you may be able to appreciate, the needle notch is 20 millimeters in width. This is a side view. The needle notch is then pulled back to straddle the wall of the stomach in order to enable a full-thickness gastric biopsy. Once the location has been ascertained, the needle is fired, taking a full-thickness gastric biopsy. The needle assembly is then removed in total, and the biopsy is removed. The process then may be repeated through the same percutaneous incision up to 4 times in the same patient.
This is the endoscopic view. First, the tracking anesthetic needle is inserted into the stomach. Then the needle biopsy assembly is inserted, and the biopsy notch is exposed. The entire assembly is then drawn back so that the biopsy notch straddles the gastric wall. Once placement is assured, the biopsy is fired, taking a full-thickness gastric biopsy. Note the minimal residual mucosal defect after the biopsy.
In our study, we did this procedure on 10 different patients that all had clinical symptoms of either gastroparesis or severe dyspepsia with abdominal pain. All patients had symptoms that were suggestive of a severe organic motility disorder. The results showed that all patients tolerated it very well. There were no complications such as bleeding, peritonitis, or significant abdominal pain beyond 24 hours. The biopsy results were successful in 9 out of the 10 patients, meaning that we were able to make a preliminary histological diagnosis based on the tissue that was harvested. In 4 out of the 10 patients, there were actual histological abnormalities seen that could potentially change the management of their patient's clinical course. For example, in 2 out of the 10 patients, we found evidence of significant fibrosis in the muscle layers of the wall of the gut that is consistent with a degenerative leiomyopathy. In 1 other patient, we did see evidence of inflammatory cells in the muscle consistent with an inflammatory leiomyopathy. And in 1 further patient, there was clear evidence of decreased numbers of interstitial cells of Cajal compared to normal controls. All of these patients likely have an organic motility disorder that is now confirmed. The conclusion of this study is that the peat biopsy technique is a very straightforward and safe procedure to do in this initial experience of 10 patients. The advantages of this procedure are that it's very easy to do as an outpatient test, and we did it during the course of a normal upper endoscopy. The total procedure time in every case was less than 30 minutes, and that included a full upper endoscopic investigation. The disadvantage of this procedure is that the biopsies are small. Typically, the average size of the biopsy is about 1 millimeter by 3 millimeters. That may not be enough tissue to adequately assess conclusively whether a neuromuscular disorder of the gut exists. In comparison, a laparoscopic full-thickness biopsy is typically about 1 centimeter squared, which gives much more tissue for analysis. We envision that this process may be a trade-off in that the ease of doing this study will outweigh the small amount of tissue that you obtain. And certainly it may be reasonable to consider it as a first-line test for patients with suspected gastric neuromuscular disorders instead of going directly to a laparoscopic full-thickness biopsy with its attendant risks and invasiveness. Thank you.